Let's get something straight before we dive in. I'm not here to scare you away from modern medicine. Surgery saves lives. Surgeons are brilliant, highly trained professionals. But here's the uncomfortable truth that doesn't get talked about enough. The human body at 63 is not the same body it was at 45. Your tissues heal slower, your blood vessels are stiffer. Anesthesia hits differently when your liver and kidneys have been working for 6 decades straight. Your immune system, the army that fights off post-surgical infections, has been through a long war and it's running low on soldiers. According to data published in The Lancet, patients over 65 account for nearly 40% of all surgical procedures in the United States, but they experience more than 50% of all post-operative complications and nearly 80% of surgical deaths. Read that again. 80%. And the tricky part? Many of these surgeries are elective. That means they're chosen, not forced. They're scheduled on a Tuesday afternoon, not rushed in an ambulance at 2 in the morning, which means there's time. Time to ask harder questions, time to explore alternatives, time to decide whether the risk is truly worth the reward. So let's talk about the 5 procedures I'd want my own mother, my own father, to think twice about. Surgery number 1. Spinal fusion for chronic back pain. If you're over 60, chances are your back hurts. Maybe it's been hurting for years. That deep, grinding ache in your lower spine that makes getting out of a car feel like climbing a wall. You've tried the heating pads, the ibuprofen, the physical therapy sessions in that room that smells like rubbing alcohol and rubber mats. And then one day, an orthopedic surgeon looks at your MRI, points to a narrowed disc or a slipped vertebra, and says the words you've been half dreading, half hoping to hear. I think we should consider spinal fusion. Spinal fusion sounds like a solution. They go in, they lock 2 or more vertebrae together with metal rods and screws, and the idea is that if those bones can't move anymore, they can't cause pain. Simple, right? Except it's not simple at all, not after 60. A major study published in the journal Spine followed over 1,200 patients who underwent lumbar spinal fusion for degenerative conditions. Among patients over 65, nearly 1 in 4 experienced a significant complication: infection, blood clots, nerve damage, hardware failure. And here's the part that stops me cold. A substantial percentage of older patients reported the same level of pain or worse pain 2 years after the surgery than they had before it. The recovery alone is brutal. We're talking 3 to 6 months of extremely limited mobility. For a 38-year-old with a strong cardiovascular system and dense muscle mass, that's manageable. For a 68-year-old with mild osteoporosis and a heart that's already working overtime, those months of immobility can trigger blood clots in the legs, pneumonia from shallow breathing, muscle wasting that never fully reverses, and a depressive episode that no one saw coming. What I'd want my family to explore first: epidural steroid injections, targeted physical therapy with a geriatric specialist, aquatic therapy, nerve ablation procedures that are minimally invasive. The back pain may never vanish completely, but managing it without fusing your spine together might give you far more years of actual living. Surgery number 2, bilateral knee replacement. Both knees at once. Now, a single knee replacement after 60, that's a conversation worth having. Millions of seniors get one knee done and return to walking, gardening, playing with grandchildren on the floor. The success rates are genuinely good. But both knees at the same time, that's where I pump the brakes hard. Bilateral total knee replacement means they open up both legs in a single operation. The appeal is obvious: 1 surgery, 1 hospital stay, 1 recovery period instead of 2. Your surgeon might frame it as efficient. Insurance might even prefer it. But efficiency is a word for spreadsheets, not for your 67-year-old father's body on an operating table. The operation time nearly doubles. You're under general anesthesia for 3 to 4 hours instead of 90 minutes. Blood loss increases dramatically. A study from the Journal of Bone and Joint Surgery found that patients over 60 who underwent simultaneous bilateral knee replacement had a significantly higher rate of cardiac events, pulmonary embolism. That's a blood clot that travels to your lungs, and a mortality rate that was meaningfully elevated compared to patients who simply had one knee done, recovered, and then came back for the second. Think about that for a moment. Your body is already marshaling every resource it has to heal one demolished knee joint, torn tissue, severed muscle fibers, a foreign titanium implant your immune system is trying to make sense of. And now you're asking it to do that identical job simultaneously on the other side? At an age when your bone density is declining, your blood doesn't clot as quickly, and your heart has to work harder to push oxygen to healing tissue? I watched a neighbor go through this. Carl was 69, a retired electrician, strong as a fence post his whole life. He did both knees on a Wednesday. By Friday, he had a pulmonary embolism. He spent 11 days in the ICU, lost 22 pounds of muscle, and 18 months later he was still using a walker. His wife told my mother he wished every single day he'd just done one at a time. If someone in my family needed both knees replaced, I'd insist on staging them 4 to 6 months apart. Yes, it means 2 recoveries. But it also means 2 recoveries your body can actually handle. Surgery. Number 3. Elective gallbladder removal. This one surprises people because gallbladder surgery, laparoscopic cholecystectomy, if you want the medical name, is one of the most commonly performed operations in America. Over 700,000 a year. Surgeons sometimes joke that it's the bread and butter of general surgery. 4 tiny incisions, a camera, and the gallbladder comes out in under an hour, home by dinner. And for a healthy 40-year-old with painful gallstones that keep landing her in the emergency room? Absolutely. Take it out. Move on. But here's what changes after 60. First, the laparoscopic part doesn't always stay laparoscopic. In older patients, the gallbladder is more likely to be inflamed, scarred, or adhered to surrounding organs from decades of low-grade irritation. When the surgeon gets the camera in there and finds a mess of scar tissue stuck to the liver and the bile duct, they have to convert to an open surgery, a much larger incision, a much longer recovery, a much higher risk of complications. Studies show that conversion rates from laparoscopic to open surgery are significantly higher in patients over 65. Second, bile duct injuries. The common bile duct, a tiny tube about the width of a drinking straw that carries bile from the liver to the intestine, runs right next to the gallbladder. In older patients with chronic inflammation and distorted anatomy, that duct is easier to nick, clip, or sever during the procedure. A bile duct injury is one of the most devastating complications in abdominal surgery. It can lead to months of drainage tubes, multiple corrective operations, liver damage, and, in severe cases, outcomes that are irreversible. Third, and this is the part many seniors don't hear, not all gallstones need to come out. If you have silent gallstones, meaning they showed up on an ultrasound for something else but aren't causing you pain, nausea, or repeated attacks, the current medical consensus from the American College of Gastroenterology is to leave them alone. Watchful waiting. The risk of surgery may outweigh the risk of stones that might never bother you. If my mother called me and said the doctor found gallstones and wanted to schedule surgery, my first question would be, are they actually causing problems? How often? How severe? And have we exhausted dietary management, bile acid medications, and careful monitoring before we put a 70-year-old woman under general anesthesia and start cutting near her liver? If you're over 60, or if you're caring for an elderly parent, a spouse, a loved one, please keep watching. I truly believe this information could change a medical decision in your family. And if anything I've said so far has made you think, drop a comment below. Tell me which surgery surprised you. I read every single one. Surgery number 4, coronary artery bypass. Grafting when less invasive options exist. Coronary artery bypass grafting, CABG, or what most people just call bypass surgery, involves cracking open your chest, spreading your rib cage apart, stopping your heart, and grafting new blood vessels around blocked coronary arteries. It is one of the most impressive achievements in the history of medicine, and for patients with severe multivessel coronary artery disease who are in immediate danger, it is a lifesaver. Full stop. But after 60, and especially after 70, the question is no longer just, can we do this surgery? The question becomes, should we? And what happens to this particular human being afterward? The sternum, that flat bone running down the center of your chest, has to be sawed in half to access the heart. In a younger patient with dense, healthy bone, it heals back together in 6 to 8 weeks. In an older patient, especially one with osteoporosis or diabetes, that bone may take 4 to 6 months to heal, if it heals cleanly at all. Sternal wound infections in elderly patients can become life-threatening. The smell of a wound that isn't healing, that warm, sour tang that you catch when the dressing comes off, it's the kind of thing that keeps families up at night. Cognitive decline after bypass surgery is another shadow that doesn't get enough sunlight. Researchers at Duke University found that a significant percentage of patients over 60 experienced measurable cognitive impairment, memory loss, difficulty concentrating, confusion in the months following bypass surgery. Some recovered, some didn't. The medical community calls it pump head, a casual nickname for something that is anything but casual when it's your father who can't remember where he put his glasses, his keys, the names of old friends. The critical question to ask, and I mean demand an answer to, is whether percutaneous coronary intervention, commonly called a stent procedure, could accomplish a similar result. A stent is threaded through a small incision in the wrist or groin, guided to the blocked artery and expanded to hold it open. No cracked sternum, no heart-lung bypass machine, dramatically shorter recovery. For many elderly patients with 1 or 2 blocked arteries, outcomes with stents are comparable to bypass surgery with a fraction of the trauma. Not every case qualifies for a stent. Some blockage patterns genuinely require bypass. But if my father's cardiologist recommended open-heart surgery, I would get a second opinion from an interventional cardiologist before anyone picked up a bone saw. Every single time. Surgery number 5. Radical prostatectomy for low-grade prostate cancer. Gentlemen, this one is for you, and for the wives, daughters, and sons who love you. Prostate cancer is extraordinarily common in older men. By the age of 70, a significant number of men have some cancerous cells in their prostate. But here's the critical distinction that gets lost in the panic of a cancer diagnosis. Not all prostate cancers are created equal. Many of them are slow-growing, low-grade tumors that will never spread, never cause symptoms, and never shorten your life by a single day. As urologists sometimes put it, many men die with prostate cancer, not from it. Radical prostatectomy, the complete surgical removal of the prostate gland, is a major operation. The prostate sits deep in the pelvis, nestled against the bladder and wrapped in a web of delicate nerves that control urinary continence and sexual function. Even in the hands of the most skilled robotic surgeon, the complication profile after 65 is sobering. Urinary incontinence. We're talking about a grown man wearing absorbent pads because he can't reliably control his bladder. For some men, this resolves in weeks. For others, it persists for months. For a smaller but very real group, it becomes permanent. The smell of urine on clothing that you thought you'd caught in time. The anxiety of standing up from a chair in public. The quiet, grinding humiliation that nobody talks about at dinner. Erectile dysfunction. The nerves responsible for erection run along both sides of the prostate like 2 thin electrical wires taped to a pipe. Even with nerve-sparing surgical techniques, a substantial percentage of men over 60 experience significant or complete loss of erectile function after prostatectomy, and at an age when intimacy with a partner already requires more patience and tenderness, losing that capacity can fracture something emotional that no surgeon can repair. A landmark study called the PROTECT trial, published in the New England Journal of Medicine, followed men with localized prostate cancer for over 15 years. The results showed that for low-grade and intermediate-grade tumors, there was no significant difference in prostate cancer-specific mortality between men who had surgery, men who had radiation, and men who chose active surveillance, meaning they did nothing but monitor the cancer with regular PSA tests and biopsies. Let that settle in. For many older men, doing nothing watching and waiting, produced survival rates that were statistically indistinguishable from having your prostate cut out. If my father received a low-grade prostate cancer diagnosis at 67, I would sit across from him at the kitchen table, pour 2 cups of strong black coffee, and say, "Dad, let's get a second opinion. Let's talk to a medical oncologist, not just the surgeon. Let's look at active surveillance. Let's make sure we're not trading the last good years of your life for a surgery you might never have needed. 5 surgeries, spinal fusion, bilateral knee replacement, elective gallbladder removal, coronary bypass, radical prostatectomy. Every single one of them has a place in medicine. Every single one of them saves lives under the right circumstances. I am not telling you to refuse surgery. I am telling you to refuse to be passive about the decision. After 60, your body forgives less. It heals slower. The margin between a successful recovery and a catastrophic complication gets thinner with every passing year, like paper held up to light. And the medical system, as brilliant and well-intentioned as it is, runs on momentum. A diagnosis leads to a referral leads to a consultation leads to a scheduled date, and before anyone pauses to ask, but is this truly the best option for this person at this age, with this body? You're already in a hospital gown with a plastic bracelet on your wrist. Slow it down. Ask the uncomfortable questions. Get the second opinion, even if your doctor seems annoyed. Bring your son, your daughter, your spouse into the room. Another set of ears, another voice willing to say, wait. You have earned every year you've lived. Protect the ones you have left with the same ferocity you brought to everything else. If this video helped you see something differently, I need you to do 3 things for me. First, hit that subscribe button and tap the bell so you never miss a senior health video. I make these specifically for you, and there's so much more coming. Second, share this video right now with someone you love who's over 60. Send it to your mom, text it to your brother, post it in your family group chat. You never know which conversation it might start that ends up saving someone from a surgery they didn't need. And third, leave me a comment. Tell me, have you or someone you love gone through one of these surgeries? What was the experience? Your story might be the exact thing another viewer needs to hear tonight. Take care of yourselves. I'll see you in the next one.